morning, my dear friends and my colleagues from Uganda and from Kenya. My name is Professor Konkov. I'm professor of the Vinnytsya National Medical University, Department of Obstetrics and Gynecology, #1. I am director of the Simulation Center of our university, and I am the secretary of the Ukrainian Associated Medical Simulation in Ukraine too. Today, very interesting topic, a topic about the current strategies for prediction and prevention of the perinatal loss. Today, you will talk about the main problems, the main questions, and maybe the answers for the more optimal prediction and prevention of the perinatal pathology like preeclampsia. The maternal cardiovascular system undergoes critical anatomical and the functional adaptation to achieve a successful pregnancy outcome, which, if disrupted, can result in the complication that significantly affect maternal and fetal health, including to the high blood pressure, gestational diabetes, kidney disorder, heart disease, and urinary tract infection and the cervical incompetence. Complications that involve the maternal cardiovascular system are among the most common disorders of pregnancies, including gestational hypertension and preeclampsia. Okay, my colleague says the central features for the maternal endothelial dysfunction is hepatitis to play in the predominant role in mediating the pathogenesis of these high-risk pregnancies, and as such might proceed and precipitate the clinical presentation of this pregnancy disorder, improving or normalizing maternal endothelial function in high-risk pregnancies might be an effective therapeutic strategy to ameliorate maternal and fetal clinical outcome. According to the pathophysiological basis of preeclampsia, yes, this basis remains an enigma with multiple plausible etiological theories involving the combination on environmental, immunological, and genetic factors that located in my slide 2. The conventional leading hypothesis, which has stood the test of time for the initial pathophysiological insult in preeclampsia, is inadequate trophoblast invasion, and thus incomplete remodulating of the uterine spiral arteries. This leads to placental ischemia, hypoxia, and thus oxidative stress. The placental hypoxemia sets off a biochemical cascade of angiogenic and anti-angiogenic factors, which leads to subsequent endothelial cell dysfunction with its observed maternal signs and symptoms of the preeclampsia. Whilst placental hypoxemia and the subsequent oxidative stress is a significant contributing factors, we acknowledge that a definitive link between preeclampsia and placental hypoxia is not confirmed, and further research is required. However, not every pregnancy is characterized by abnormal placentation results in preeclampsia. Fetal growth restriction is one such example in where there is suboptimal placentation with detrimental fetal effects, but minimal maternal effects. One possible reason for the development of preeclampsia is that the recent concurrent maladaptation of maternal cardiovascular function, along with abnormal placentation, and this predisposes an individual to development of the preeclampsia. This would also explain why not all women with poor placentation, with its circulate such as fetal growth restriction, development preeclampsia. The cardiovascular system adapts appropriately to ongoing pregnancy and associated hemodynamic change. Several theories involving an exaggerated maternal systemic inflammatory response and increased systemic levels of oxidative stress have been published in the past during spiral artery remodulating, according to my slide. The vessel structure changes with loss of the vascular cells, and this increases the sizes of the artery and creates a high flow in low resistance vessels. This change are brought about the partially by maternal immune cells, like the decidual natural killer cells and macrophages, with the change completed by invading interstitial and endovascular trophoblast. The remodulated vessels consist of trophoblast embedded in the fibrinoid material as their replacement, with subsequent re-endothelialization occurring later in the pregnancy. Pre-pregnancy concealing may be a significant benefit in women who are known to have chronic hypertension, prior preeclampsia, diabetes, multifetal pregnancy, antiphospholipid syndrome, systemic lupus erythematosus, chronic kidney disease. All women planning in the pregnancy should be encouraged to attend their primary health care provided to identify hitherto and recognize hypertension and start on the correct management. This also represents an opportunity for concealing regarding lifestyle modification, especially weight optimization, and to recommend early booking for the women with risk for the preeclampsia, including chronic hypertension, obesity, diabetes, antiphospholipid syndrome, multiple pregnancy, especially assisted reproductive technology or side donation. A woman taking angiotensin converting enzymes inhibitors and angiotensin II receptors blockers should be informed of an increased risk of adverse fetal outcome of these drugs are taken during pregnancy. Both these drugs form part of the first-line management of the blood pressure control outside pregnancy and also optimize proteinuria. Pre-pregnancy counseling will identify women who are using this and other potentially unsuitable drugs, such as diuretics and high doses of the beta blockers. In patients with reliable access to care, these drugs only need to be changed once a pregnancy is confirmed. Clinicians may choose to avoid these drugs in women who are at the risk of unplanned pregnancy, like in the lower resources countries, more often that may be detected late. If the testing available, women should be screened in the gestational age, 11, 14 weeks, using the combination of the clinical risk marker and biochemical and ultrasound, including like fetal cross-rump length, uterine artery, and the mean arterial blood pressure, pulsative index of the uterine artery, and the calculating the MOM, maternal serum PAP, and maternal serum placental growth factor is available. Mean arterial blood pressure has been demonstrated to be more predictive of preeclampsia among low-risk women than either systolic blood pressure or diastolic blood pressure readings alone. Blood pressure measured in the both arms simultaneously with the average for calculated of the mean arterial blood pressure measurements may assist with the risk stratification for preeclampsia development. In the first trimester, risk screening. In addition to maternal history and the clinical risk and the mean arterial blood pressure, consider additional testing if the clinically indicated, like placental growth factor, lowered level in the woman, and the risk of preeclampsia and the fetal aneuploidy and or impaired placentation disorder, which can also be associated with preeclampsia. Positive predictive detection value of 60% for preeclampsia. Another one, uterine artery pulsative index, measured between 11 and 14 weeks gestation. Positive predictive detection value, 50% for early onset preeclampsia. Pregnancy-associated plasma protein A, like SPAP-A, levels less than 0.4 multiple of medium, associated with increased risk of the hypertensive disorder in pregnancy, preterm birth, and the fetal growth restriction. And the positive predictive detection, 25%. According to the online calculator, it is absolutely free, and you find it in the Fetal Medicine organization and the Medicine Fetal Barcelona organization too. It's maybe more easy for the adequate prediction of the preeclampsia. Another useful test, like is placental growth factor. Yes, you can use it not only for the first trimester of pregnancy, and you can use it too for the second and for the third trimester. These models have been developed at the range of gestations, including the second and the third trimester, but are likely to be in the greatest utility in the first trimester, when the capacity to prevent disease, the key principles of the screening, is greatest. And the summary of some of these multiparametric models and their performance in the cohort in which they were developed is contained in our table. It's like a parrot investigation, and the recommends on our slide. Yes, and according to another useful strategy for the prevention, it's like a relationship between free tyrosine kinase and placental growth factor, especially after 20 weeks of gestational age. And according to the level 38, it indicates of the high negative predictive value, approximately 90, just a moment, and approximately 99% to exclude current diagnosis. Greater than or equal to 38 indicates a low positive predictive value, like for the 37% for the preeclampsia development with 4 weeks in the singleton pregnancy. Greater than or equal for the 85 years, and it indicates in the high likelihood of the having preeclampsia sensitivity 88%, and greater than or equal to 110, that indicates in the high likelihood of having preeclampsia, and sensitivity and specificity approximately 60 and 95%. Yes, my students, it's this relationship is maybe more useful for diagnosis, not only for the early onset preeclampsia, like for the late onset preeclampsia too. Another one, like for the women in the increased risk of preeclampsia who are overweight or obese, dietary advice, reduce calories and choose foods with a low glycemic index, like in our slide, and exercise and morning exercise are recommended. And according to more perspective prevention, and really like is the current prevention strategy. For the current prevention strategy in our slide, it's like within the low dose of the aspirin. Why? Because in this, like, it's a vascular mechanism for decrease of the inflammation, decrease of the platelet activation, and decrease of the angiogenic imbalance, increase of the inflammation production. It's like it's more specific for statin, and increase of the NO synthesis and bioavailability. Calcium, decrease of the vasoconstriction. Vitamin D, like decrease of the inflammation. Aerobic exercise, in the same mechanism like is for the statin, in decrease of the inflammation and increase of the nitric oxide synthesis. Yes, my students, you can use not only lifestyle change. We can use, especially for the woman who has the highest risk of preeclampsia, aspirin. For women in increased risk of preeclampsia, low doses of acetyl salicylic acid from 100 milligram till 150 milligram per day is recommended to be taken at bedtime, preferably from the 12 weeks gestation, and discontinued by 36 weeks gestation. Many analyses suggest that aspirin doses less than 150 milligram may not be reducing the risk preterm preeclampsia sufficiently. The many results indicate the dose of the 150 milligram may provide up to 65% reduction of preterm preeclampsia. The effect of the aspirin on COX-dependent prostaglandin synthesis is dose-dependent. At the lower dosage, less than 100 milligram per day, aspirin irreversibly acetylase COX-1, resulting in decreases platelet synthesis of thromboxane without affecting vascular wall production of prostacyclin. At the higher doses, aspirin inhibits both COX-1 and COX-2, effectively blocking all prostaglandin production, and blocking COX-2 decreases sensitivity to angiotensin II, decreases the activation of the immune system, and decreases oxidative stress too. High doses aspirin may be in the best option, allowing for restoration of angiogenic balance and improvement in the vascular function associated with preeclampsia. Another one, calcium. WHO recommended that all pregnant women from areas of the low dietary calcium, recommended in addition to aspirin. Insufficient evidence to recommend routine use for all women. WHO has updated the evidence in 2020 years, stating that pre-pregnancy calcium supplementation for the prevention of the preeclampsia in its complication is recommended only in the context of the regrowth research. As the recent study suggests that pre-pregnancy low doses of the calcium supplementation, like 500 milligram per day, benefited women with a history of preeclampsia. For other nutrients such as vitamin D, folic acid, and fatty acid supplementation, as well as sodium intake reduction, there is limited evidence of their role in the prevention of preeclampsia. There has been increased research momentum to identify new therapeutic strategy in the world. According to the molecular targets for candidate treatment include oxidative stress, angiogenic factors, and angiotensin, nitric oxide, and pro-inflammatory pathways. The proposed treatment undergoing preclinical and clinical trial evaluation are thought to act on placental and endothelial disease or both. Most have adopted the pragmatic strategy of repurposing drugs. Of all the therapeutic agents proposed, pravastatin maybe has received the most interest. There are preclinical studies showing that it has pleiotropic actions that favorably impact in the multiple molecular target and can result in preeclampsia phenotype. There is also experimental in vitro evidence that it resolves endothelial function, and the several experiments size, like it reduces expression of the vascular cells adhesion molecule, like vascular, like is in the vascular endothelial, and endothelin 1, and leukocytes adhesion in endothelial cells, and increases endothelial cells migration and adhesion too. This means that it could beneficially act in both the placenta and maternal vascular disease, like in our slide, please, attention. There is also evidence that pravastatin can reduce circulation-free form of the tyrosine kinase, decrease inflammation, and upregulate nitric oxide synthase. Proton pump inhibitors like lansoprazole, rabeprazole, and esomeprazole can decrease placental release of the soluble form of the tyrosine kinase, insoluble endoglin. Proton pump inhibitors are well tolerated. Furthermore, there are safety data from very large cohorts, concluding that there is no teratogenic effect, even after first trimester exposure. A meta-analysis has reported an association between prenatal exposure and childhood asthma, but it's unclear whatever the lens is causative or whether confounding variables may explain the finding. And according to another prospective studies for the special endothelial protector agents, it's like arginine. Preeclampsia, similar to the malaria, in pregnancy is characterized by endothelial dysfunction and placental insufficiency. An initial trial of arginine supplementation in pregnancy was underpowered and lower quality, although it reported reductions in the maternal blood pressure and fetal growth restriction cases. Better designed, yet still generally underpowered randomized controlled trials followed to evaluated longer-term low doses arginine supplementation, like 3 grams per day, or maybe 3 grams per day for 3 weeks in preeclampsia, and observed significantly improvement to maternal and fetal hemodynamic as well as better fetal outcome. In contrast, in the two trials in preeclampsia, women using short-term moderate doses initiated later in pregnancy, 12 grams for 5 days, observed no benefit. This data suggests that short-term supplementation, especially late in pregnancy, is insufficient to improve maternal hemodynamic. The observations are consistent. The human and preclinical data indicating that interventions to the affect placental vascular insufficiency via the arginine nitric oxide pathway need be initiated early and continued over the course of pregnancy. about from 12 weeks of gestational age. 4 published randomized clinical guidelines and clinical trials have investigated arginine supplementation in the context of the gestational hypertension, like in our slide. The first 3 studies assessed the acute effects of the large doses of the arginine, like 20 gram intravenous once or for 5 days. Relatively late in the pregnancy, whereas one study was small, the other was in the large, like the 15 women and 123 women. Both studies reported that parenteral arginine decreased maternal blood pressure, but neither reported on the pregnancy outcomes. In the absence of the evidence of improved clinical outcomes and given the challenges of the long-term parenteral arginine administration, it's unclear whether this is the feasible therapeutic approach. Collectively, the exciting data support the use of the longer-term low doses arginine supplementation as the regimen most likely to improve maternal and fetal outcomes on hypertensive disorder in pregnancy. Our investigation and the previous investigation, it's like in a special communique from the Mr. Nikolaidis. And Mr. Nikolaidis talking about the special findings suggest the development of early preeclampsia in associated with altered nitric oxide metabolism, reduces concentration of the L-arginine, could result in impaired synthesis of the NO. And the early preeclampsia is associated with impaired trophoblastic invasion of the maternal spiral artery and like the disorder of the adequate implantation, and maybe like a trigger for development of gestational endotheliopathy. And we can use arginine is like for the prevent strategy of the placental disorder like preeclampsia. L-arginine supplementation in the pregnancy with hypertonic disease, hypertension disease or disorder, especially the pregnancies and the complicated by hypertension, may result in the systemic arterial spasm and placental circulation disorder, and they increase the risk for the adverse birth outcomes. In the study, the increased birth weight and longer gestational age, including L-arginine treatment for the hypertensive disorder pregnancy. Previous study indicated that L-arginine administration induced a persistent decrease in the maternal blood pressure, both in the preeclampsia. And according to Reed and according to results the L-arginine, supplementation had a greater effect in the birth weight in the hypertensive disorder patients without proteinuria, and indicates that the greater placental vascular development damage is unlikely to be reversed with intervention, and that L-arginine treatment should be used in the mild symptom stage, but more methodologically well-conducted studies are needed to evaluate its real impact in the clinical practice, our clinical practice. And don't forget, my colleagues, my dear colleagues, association among pre-pregnancy risk factors, the hypertensive disorder of the pregnancy, and especially for lady who has the comorbid disease like the obesity, diabetes mellitus, hypertension, including to the hypertensive disorder in the pregnancy, like is gestational hypertension and preeclampsia, especially with preterm delivery and intrauterine growth restriction and retardation, in this, like is in the cause of the risk, coronary artery disease, cardiovascular disease, stroke, heart failure, and the hypertension. And attention, my dear colleagues, and attention is the highest risk of the maternal mortality, more than 3 times. Because of the predictive strategy in the pregnancy and the good predictive strategy for the prolong of the life of your patient. Our final comment is that although there has been a pleasing increase in the clinical trial of the new candidates to treat or prevent preeclampsia, the overall number remains modest when compared with other specialties. A review in the field of oncology lamented that of 5,000 to 10,000 drugs in oncology approved by the Federal Drug Administration, only 5% survived trial to reach the market. If our own therapeutic fields was functioning even at 1% of the scale, it would mean in the theory that we will have around 3 to 5 additional agents to use to prevent of preeclampsia, to add to the sole agent we have, like is aspirin. Conversely, for the new drugs to be clinically acceptable to prevent preeclampsia, it would need to be exceptionally safe. The reason is that our screening approach to identify women at the risk of preeclampsia having a modest value in accurately predicting preeclampsia. That is a low positive predictive value. This means any preventative treatment will be administered for the many months to far more pregnancies that were never destined to develop the condition than those that were. In the contrast, the threshold at which we may tolerate it, uncertainty around safety may be lower than contemplating pregnancy treatments for the clinical preeclampsia. This is because for the treatment trial, it would be anticipated that the drugs will be given to the select few for a few weeks, if not days, and well clear to early pregnancy when the teratogenic risk is greatest. Supplementary treatment with the L-arginine, like Tivortin, may represent a new safe and effective strategy to improve endothelial and vascular function in the various pregnancy complications in the patient with placental disorders. Our current findings revealed that supplementation of the L-arginine prevent not only preeclampsia and prevent the intrauterine growth restriction or retardation, especially when you start these drugs during first and the second wave of the trophoblastic invasion, like from the 12 weeks of gestational age. Thank you very much, my dear colleagues. And if you will have some questions, please ask me.